there's something wrong with the shoulder, and then we may do some therapy, we may do an injection, we may do a few things to see how they do. But if they don't get well after a few things, then the next step typically is an MRI. The MRI is to determine what kind of damage is done in the shoulder and what kind of damage would help us determine what do we do next, okay? So again, first few steps before we get to an MRI, but the MRI is important in determining how we proceed. Some MRIs will tell us, well, we don't have to do anything. Some MRIs will say we need to do something, we should probably do something pretty quick, okay? So you'll see in the pictures, there's gonna be a few pictures throughout this video. The first picture we're gonna show is the rotator cuff in normal state. So if you look at the rotator cuff and we look at it, we look at the attachment of where the rotator cuff goes onto the bone, that piece of the bone, which is the proximal or the top of the shoulder joint, the ball part of the joint, is called the greater tuberosity. So you have the ball, as you can see, you have the ball, and the little bump. That little bump is where the rotator cuff attaches. And so we have a certain thickness of the rotator cuff that attaches there, and that certain thickness is normal. Depending on the person, some people have a little bit thicker, some are a little bit thinner, but there's always a certain amount that's attached there. And we can see what's attached, and we can often see what's not attached as well. So the first picture that you're gonna see, we'll pull it up, that's the full thickness, the full rotator cuff attachment, so a normal rotator cuff, okay? And what we're talking about right now is really just the supraspinatus. The rotator cuff has 4 tendons, the supraspinatus, the infraspinatus, the subscapularis, and the teres minor. The 4 tendons are important in cuffing and holding the ball in the socket. But the most commonly torn rotator cuff is the supraspinatus, which is the one the top in the front. And so that's why people often have pain in the shoulder here, because that's where it starts. That's where the rotator cuff tear starts. It may progress from the supra into the infraspinatus, but it almost always starts in the supra. Okay, and so these pictures, these images, the illustrations are of specifically talking about the supraspinatus, not necessarily the rest of the tendons, but it goes along with the theme that what's most important, what most people need to understand is the supraspinatus tendon, not the other tendons necessarily. That image, see normal, full strength, full attachment of the rotator cuff. And then we talk about partial thickness tears. So again, we see the thickness of the rotator cuff and we can tear part of the way through. So not all the way through, just part of the way through. And we have 2 determining factors of our qualifiers, right? We'll say a low grade partial tear, which just kind of goes through a little bit of the rotator cuff. And then we have a high grade, which may go through almost all of it. Now, it's sometimes hard to tell exactly how high or how low it is on the MRI, but we can get a general thought of it looks like it's almost all the way torn or it looks like it's barely torn. This is crucial in that if it looks like it's all the way torn, most likely in progression of the disease, progression of the problem with the rotator cuff, that rotator cuff is going to go completely torn. And so it matters in that when we counsel someone, we may not say, hey, it's not urgent to get this done right away, but we may say, most likely this is going to progress to a full thickness tear, so we need to be very diligent in monitoring this and determining if the symptoms change, that we may have to be more aggressive in going ahead and doing a surgery to fix the rotator cuff. If it's a low-grade partial tear, right, if it's only through a little bit, we say, you know what, it's low grade, probably is not going to proceed to a high grade. It most likely is not. That being said, on the other side of it, if we have some pain and it's unable to get relieved with therapy, injections, and all those kind of things, then there may be a role for us to go in there and trim out the low-grade partial tear that may encourage the rotator cuff to heal. And so we have kind of 2 ends of that. The high grade may say, we don't have to do anything now, but we're gonna have to watch it closely. Or the low grade, we don't have to do anything now, but if it's really hurt, maybe we should do something now or do something in the near future. So that's the partial thickness tears of the rotator cuff. And then we have a full thickness tear. The full thickness tear obviously is, as you would expect, is all the way through. Now, all the way through means that it's all the way through. It doesn't mean it's all the way through all 4 tendons, right? So if we have a supra, infra, and teres minor, and subscapularis, we may say it's all the way through a part of the supraspinatus. Because you can go through, let's say if the supraspinatus is this thick, but it's this wide, right? So it's this wide too. So you can go through all the way through the thickness of it, but you may not go through all of the width of it. And so we'll say it is a full thickness tear of the supraspinatus, but it will only be the front of the supraspinatus, or it may be most of the supraspinatus, or it's the supraspinatus but not the infraspinatus. So that full thickness tear is important, because if it's a full thickness tear, it most likely is going to progress. It is not going to heal. It's going to progress. So if it's a full thickness tear that's a small tear, over time it will become a bigger tear, bigger tear, bigger tear. So if it's small tear, then we may say, we probably should do this in a reasonable amount of time. When I say, as an orthopedic surgeon, maybe we should get this taken care of within the next 3 months, because if it's longer than that, it may get big, big, big. And sometimes when it gets really big, we actually cannot fix it and we have to do other things. And so a full thickness tear is important. Doesn't mean that we have to rush to do the surgery, but it probably means that more than likely we're going to have to do some kind of surgery at some point. And then there's another term that we talk about, retracted tear. So far you've seen an image of a normal, you've seen an image of a low grade, you've seen an image of a high grade, and you've seen an image of a full tear. And the next step after that is a retracted tear. As you can see on this image, the retracted tear, right, the ball in the rotator cuff attached to it, and now it's retracted, it's pulled away. The retracted tear is a different animal to us as orthopedic surgeons, because retracted tears that are not fixed shortly after we know about them may not be fixable. If you can imagine that retracted tear gets retracted, and if it's there for months and months and months, it's almost like the rubber band of the muscle that's back here gets weaker and weaker and tighter and gets scarred in. And so oftentimes, if it's retracted for a long time, we may not be able to get it back. Even if we do surgery, we may not be able to get it back to where it's supposed to be. If it's a big retracted tear, oftentimes we cannot. We may be able to fix part of it, or we may be able to augment, which means we may be able to put something on top of it, an additional graft to bridge it. And that works okay, but not great, not normal. And so if it's a retracted rotator cuff tear, we may be saying, you know what, we better get this taken care of quickly in the next month or so, because we don't know how hard it's going to be fixed. And if we wait longer, it'll certainly get longer. It'll take longer to fix. It may not be fixable. What if it's not fixable? Well, as I said, we can do the patch, and we can do partial repairs, not all of it. If it's not fixable, it depends on the patient. Some people who are younger and more active, there's some options. And if we're older and less active, there's some options. It's not a good thing no matter what. If they're older and of retracted full thickness tear, we may replace it with a ball and socket, which is called a reverse total shoulder. We can talk about that a little bit later, another time. If it's a younger person, it's not fixable, then we often will use the graft and hope. There's another thing, superior capsular reconstruction, it's called. That's another option. That's a complicated option as well. But this is, which is kind of beyond the scope of this video today. So essentially, normal rotator cuff, low grade, high grade. Those are the three that we say, you know what, we may be able to play with it as far as time-wise. Full thickness retracted, we don't have as much time. We should probably fix that in a shorter time frame. One more thing we talk about, there's some terminology, especially if you look at the coding of it, a technical coding of the surgeries. There's something called a complete tear. Now, a complete tear in my brain as an orthopedic surgeon would be all the rotator cuff, supra, infra, teres minor, subscapularis, all torn. It probably can't happen without dislocating the arm from the body, removing it probably can't happen. So complete is not really an accurate term, just to be complete. So full thickness, retracted, high grade, low grade, partial, normal. Those are the kind of the idea. Those are the categories to put it in. And each category has its own kind of plan for recovery, for treatment options. So hopefully this helps. If you have any questions, anything else you'd like us to talk about, please use the comments and suggestions down at the bottom, and we'll get them and we'll make videos about whatever you guys want to talk about. So again, Dan Orcutt, rotator cuff expert, and I hope you enjoyed this video.